A very good afternoon to all. I bring greetings from NIMHANS, Bangalore. At the outset, let me thank the organizers of ISACON Kerala 2021 for inviting me and giving me this opportunity to speak on anesthesia for endoscopic cranial surgery. So these will be the learning objectives of this 30 minutes lecture. I will be speaking on the indications and advantages of endoscopic neurosurgical procedure, especially focusing on cranial neurosurgeries, preoperative evaluation and preparation of patients undergoing endoscopic cranial neurosurgery, perioperative concerns and considerations of the pathologies for which they present for this kind of surgery, the anesthetic goals and perioperative management of these patients, and then lastly end with postoperative care and outcomes. Now, what are the indications for endoscopic cranial neurosurgery? The two common routes that are adopted for cranial endoscopic surgeries are the cranial route and the nasal route. The cranial route, most of the treatment that is done is for hydrocephalus, which includes endoscopic third ventriculostomy, breakage of the septations leading to hydrocephalus or loculated hydrocephalus, and to guide the shunt revisions, especially when the shunt is performed multiple times and has failed. The other indication is to perform a tumor biopsy. You don't have to perform a large craniotomy to obtain a biopsy material. A minimally invasive surgery such as the endoscopic cranial surgery is sufficient to decide on further course of management. Now, there are certain ventricular lesions such as colloid cyst or third ventricular cyst, neurocysticercosis, which can be excised or a fenestration can be performed and communicate with the ventricle, which is again a minimally invasive in nature and results in symptomatic relief for the patient. The other surgery that is commonly performed is endoscopic strip craniectomy for cranial synostosis. The next route that is used for approaching lesions is the nasal route, and the most common intervention or the treatment that is done is the transnasal transpyramidal approach for removal of pituitary tumors. Some other skull-based lesions such as chordoma can also be excised or decompressed using the nasal route. Lastly, one of the technique to reconstruct the defect in the skull base, which leads to CSF rhinuria, is can also be achieved by performing the endoscopic cranial surgery. Now, of course, there are certain advantages of endoscopic neurosurgery over open cranial neurosurgical procedures. For the surgeon, it provides better maneuverability, panoramic view, less tissue damage, better tumor resection of extensions, less cerebrospinal fluids as compared to microscopic surgery. For the patient, there is no big scar, no big incision, therefore it's less invasive and less likely to cause postoperative pain. It also is supposed to result in fewer complications, and studies have shown that endoscopic approaches result in shorter hospital stay as compared to open neurosurgeries. What is there in this for anesthesiologists? This is a faster surgery. The endoscopic surgery takes a lesser time as compared to cranial surgery, for example, pituitary surgeries. Recovery is also faster, less hemodynamic instability as compared to surgery, less blood transfusions, reduced requirement of analgesia, may not necessarily be anesthesia, and less complications to manage. So I'm going to take some of the examples such as endoscopic management of hydrocephalus, endoscopic management of pituitary lesion, and endoscopic management of cranial synostosis. These are the three broad pathologies that I'll be going to address in this presentation. And these are the three commonly performed endoscopic cranial procedures. So this is the anatomy, endoscopic anatomy head, when you consider intervention for hydrocephalus. You can see that there is a foramen of Monro. This is the third ventricle tumor. This is the choroid plexus, which secretes the CSF. These are the mammillary bodies, and just anterior to that is the site for endoscopic third ventriculostomy. This is thalamostriate vein, and this is thalamus. The bleeding mostly during endoscopy occurs from the damage to the thalamostriate vein or to the choroid plexus, or during the biopsy of the lesions. Now, this is the how endoscopic biopsy is performed. You need to devascularize before you take a biopsy to prevent bleeding. The bleeding can obscure the vision and render endoscopic approach meaningless for any treatment in neurosurgery. Now, this is endoscopic cyst excision. You can see a third ventricular lesion on MR, and here you can see the endoscopic presence of a third ventricular cyst blocking the CSF passage flow and resulting in hydrocephalus. So you need not perform endoscopic third ventriculostomy here. You can excise the cyst in toto with the endoscopic approach. Now, however, the common intervention that is performed is the endoscopic third ventriculostomy. The two mammillary bodies here located at 6, 5, and 7 o'clock. There's the basilar artery. You can see this Lilicus membrane. You can see the Fogarty's catheter has gone in after creating a rent, and there is a balloon which is inflated, and this is pulled out, and that results in a ventriculostomy. And once the ventriculostomy is performed, you can go below it and see the arachnoid, see the basilar artery very visible here, and caution has to be taken to avoid any damage to the basilar artery. We have lost one patient who had a rent in the basilar artery, and then it has to be converted to open surgery, and by the time the patient had already had a significantly raised ICP and then expired. Now, coming to the preanesthetic evaluation, remember that patients coming for ATV can present as early as in the neonatal period and also in the adults. In neonates, the physiological problems that accompany should be considered, that is poor lung compliance, immature organ function, and risk of postoperative apnea. In children, these patients would generally undergo multiple shunt revisions, can have seizures, present recurrent chest infections. So these are some of the things that should be noted in the preoperative period. And adults, these are generally disease manifestations such as raised intracranial pressure, altered sensorium, thereby rendering the patient at high risk of pulmonary aspiration. Co-morbidities in adults are common, and these should be evaluated thoroughly before the surgical procedure. Now, what are the anesthetic concerns and considerations for patient undergoing endoscopic third ventriculostomy? One is to maintain the intracranial pressure and the cerebral perfusion pressure. You should avoid acute increases in the ICP and decrease in the CPP. Airway management can be difficult, especially in children with large head, and the prolonged intubation can result in raise in the ICP and reduction in the cerebral perfusion pressure, and thereby leading to cerebral ischemia. The other consideration is to provide a still and bloodless surgical field. As I said, the blood is the enemy for endoscopic procedures. So you have to avoid patient movement, maintain low normal blood pressure. Following endoscopy, remember that it is a very short procedure. So early and smooth induction and recovery is required, and use of short-acting agents such as propofol, desflurane, or sevoflurane, and short-acting opioids such as fentanyl are desirable as compared to longer-acting agents. Another important consideration that anesthesiologists should take into account is possibility of complication in the immediate post-operative period and also in the intraoperative period. And anesthesiologists should be knowledgeable and swift in diagnosing and managing these complications. Now, as I mentioned, airway management is a concern in a patient child with large hydrocephalus, minimal availability of the brain matter, and you need to modify the techniques over and above the routine management. Here we have ramped up so that the head rests on the bed and the patient's body is elevated so that the laryngopharyngeal, the axis of intubation are in line, and it becomes easy. Coming to the anesthetic management, as I mentioned, smooth induction, swiftly secure the airway, good analgesia, adequate anesthetic depth, either IV or inhalation techniques are okay. Nitrous oxide needs to be avoided. One of the common complications post-operatively is seizures and delayed recovery. And one of the reasons is pneumocephalus, and this nitrous oxide can aggravate the occurrence of presence of air, and therefore should be preferably avoided. Now, timely and titrated relaxant dose. Again, as I mentioned, it's a short procedure. So we need to take care of and use short acting such as atraconium as a relaxant so that we have quick recovery and can take the next patient in. Monitoring ICP and cerebral perfusion can be monitored, especially what is known as the endoscopic pressure. The pressure transducer is connected to the endoscopic port and then transferred to the arterial transducer and monitored. This provides us idea and helps in preventing raise in ICP. One of the common cause for raised ICP is the blockage of the egress of the saline that is injected to maintain a clear view and avoid bleeding. It's a physiological tamponade. And therefore, when there is occlusion or prevention of any egress of the CSF or of the saline that is injected, this can result in acute rise in intracranial pressure and can result in alteration in the heart rate, such as bradycardia, tachycardia, hypertension, hypotension. Remember, a lot of fluids are administered through the endoscope, and therefore temperature changes are likely, especially when you are administering the fluids at room temperature, that is around 20 to 24 degree in AC environment, and whereas the hypothalamic temperature is around 38 to 40 degrees. So that results in temperature changes in the hypothalamus and can lead to hypothermia in the postoperative period. The content of the fluids that are administered to irrigate the field is generally normal saline or ringer lactate. These can bring about changes in the electrolytes, the hyperkalemia, hypokalemia, hyponatremia, etc. And lastly, as I mentioned, bleeding is visible on the monitor. You should be very careful, and appropriate measures be taken to minimize bleeding and manage if it occurs. Coming to the perioperative complications for endoscopic third ventriculostomy, in particular and broadly for any intracranial neuroendoscopic procedure, this was a study published from AIMS New Delhi, where they studied 223 patients, out of which almost half of them were children. And the major intraoperative complications they found was hypothermia, cardiovascular, such as tachycardia, bradycardia, hypertension, and hypotension, and probable causes they have mentioned as hypothalamic and cranial third stimulation, rise in ICP. At the end of surgery, delayed arousal is quite common. This could be because of pneumoventricle, rise in ICP, or injury to the vital structures. And post-operative ventilator support may be required in a substantial number of patients. Coming to the post-operative complications, in the immediate post-operative fever, again because of the changes in the hypothalamic temperatures, tachycardia, and post-operative nausea are common. This was from a surgical perspective from Dhaka. They shared their experience in 412 patients, and we find that bleeding was one of the common problems. Tachycardia, bradycardia, hypertension, delayed recovery, CSF leakage, electrolyte imbalance, convulsion, third nerve palsy, and death. And more than one complication was seen in about 8% of the patients. Coming to the next set of pathology and endoscopic approach is the transnasal transsphenoidal pituitary surgery. And here endoscope is channeled through the nose through the sphenoid sinus into the sella, and the pituitary tumor is removed. So this is the view that you get an endoscope where dura is seen through the sella. Here the tumor is being removed, and once the tumor is removed, you can see a nice clear area without any residue. And if there is any problem, such as bleeding, can occur, that could result in the obscuration of the views that you get in endoscopy. Now, most of the common problem that you encounter in patients undergoing endoscopic pituitary surgery is either hypo or hyperfunction of the pituitary and mass effect. So apoplexy results in hypofunction, and hormone secreting tumors result in hyperfunction of that particular hormone, and we should be carefully watching for that. The two common problems, pathologies that are of concern to the anesthesiologist are the Cushing disease and acromegaly. And therefore, I will be discussing the background of these two diseases in particular, and then the anesthetic management. So there are several surgical and anesthetic considerations that you need to take into account when you manage patients with pituitary lesions. Adequate preoperative preparation, intraoperative management plan, and postoperative care elements have to be in place. So hypercortisolism is caused by the ACTS secreting pituitary adenoma, and this is what you get: your red cheeks, acne, thinning of hair, moon face, increased facial hair, easy bruising, weight gain, purple stripe, annulus abdomen, slow wound healing, swelling of the feet and legs, thin arm and legs, weak bones, thin skin, extra fat around the neck, buffalo hump, red cheek. And common problems that are of concern to anesthesiologists are hypertension, poor short-term memory, irritability, fatigue, poor concentration, glucose intolerance, recurrent infection, and depression. Now, the perioperative concerns that anesthesiologists should keep in mind is the obesity, so it can lead to so many other problems: hypertension, osteopenia, fluid retention, hyperglycemia, metabolic alkalosis, hypokalemia, poor wound healing, easy bruising, psychosis, muscle weakness, thin extreme extremities and skin, delayed gastric emptying, and lastly, apoplexy and post-resection ACTH deficiency. These can produce in hypocortisolism. In the perioperative period, you have to prevent the cortisol deficiency, and which can result in hypotension, which is refractory unless you supplement the cortisol. And if you give the perioperative steroid, it can result in misdiagnosis regarding success of surgery, because you will not know whether there is a drop in cortisol levels after surgery, after successful excision of the adenoma. It also results in iatrogenic suppression of the hypothalamic pituitary axis. And if you don't give cortisol perioperatively, it can avoid complications associated with steroids. You have to monitor for cortisol. That is the first and foremost, glucose and electrolytes. Post-operative serum cortisol level less than 4 or pre-operative serum cortisol level less than 4 is indicative of non-functional or clinical remission. So this is an algorithm provided to manage pituitary adenoma, especially with regards to administration of corticosteroids. So here you can see that you have to perform 8 AM cortisol and ACTH test. If it is normal, there is no need for periodic glucocorticoid administration. Assess cortisol post-operatively on day 1 to day 3. Now, if the ACTH is low, if the cortisol levels are low, then you need to supplement the steroids for 48 hours, either hydrocortisone or dexamethasone, and assess again from day 3 to day 5. If the cortisol levels are low, you replace with hydrocortisone equivalent 15 to 30 milligram per day. If it is more than 450 nanogram per day, no replacement is needed. If it is between 250 to 4, only stress dose corticosteroid replacement. That is, and then regularly check it on day 7 and supplement it. Most often, if you are performing insulin tolerance test or metirapone or glucagon test at day 14 or at 4 to 6 weeks, and this is abnormal, you need to replace. If it is normal, there is no need for replacement. The next pathology for which endoscopic pituitary surgery is performed is acromegaly. This is a result of proliferation of the somatotroph cells in the pituitary adenoma, which can result in pituitary adenoma, and oversecretion of growth hormone. Remember that growth hormone mediates the synthesis of target gene insulin-like growth factor 1, and this brings about the metabolic changes and somatic growth, which can also contribute to mortality. Now, how do these patients present? They present mainly with 2 ways. One is the local mass effect, which results in headache, visual field effects, and hypopituitarism. And second is the systemic manifestation of growth hormone excess. Now, growth hormone, whenever it is a functional pituitary adenoma, these symptoms are likely to occur first as compared to the local mass effect. So you have hand and foot enlargement, hyperhidrosis, increased skin thickness, darkening and thickening of the body hair, frontal skull bossing, coarsening of the skull features, widening of the maxilla, separation of teeth, jaw malocclusion, soft tissue enlargement, skeletal overgrowth, deep and husky voice, and ventilatory dysfunction, again of important concern to anesthesiologists, weight gain, joint pain, and sleep apnea. So this is a pictorial depiction of how a patient with acromegaly looks like, which I already covered. Now, there are important co-morbidities that are associated with acromegaly, which anesthesiologists should assess and be prepared for. The most common amongst them is the cardiovascular comorbidity, such as hypertension, arrhythmias, cardiomyopathy, left ventricular hypertrophy, and congestive heart failure. And the vascular abnormalities include atherosclerosis and endothelial dysfunction. Amongst respiratory problems, the obstructive sleep apnea is the most common, with a prevalence of between 60 to 80%, whereas in the general population is only about 2 to 25%. There are morphological changes which occur in the tongue, such as macroglossia, upper airway obstruction, and all these can lead to ventilatory dysfunction. Among the metabolic problems, insulin resistance, impaired glucose and lipid metabolism, and diabetes mellitus are the common comorbidities. Organ enlargement, colonal polyp, fluid and salt retention, and renal failure are some of the visceral comorbidities associated with acromegaly. Lastly, and most obvious, is the musculoskeletal abnormalities such as arthropathy, osteoarthritis, facial changes, limb changes, carpal tunnel syndrome, and osteopenia. Now, in the preoperative evaluation, airway assessment becomes important, and ENT specialist can assess the airway using indirect laryngoscopy or flexible vibroptic scope. Cardiorespiratory status has to be evaluated in view of the pre-existing comorbidities in the cardiovascular system, and echo and echocardiogram and pulmonary function tests are desirable in these patients. Because it is a multi-system disease, consultation from the endocrine team, the cardiologist, ophthalmologist need to be taken. The hormone levels has to be assessed before and after surgery. X-rays to perform to look for any systemic skeletal changes. And lastly, MRI of the brain to get details about the pituitary adenoma. We should also have a surgical, anesthetic, and post-operative plan in place, considering that significant anatomical and physiological changes are present in these patients. You can see that on physical examination, there is a dysmorphic face, large fingers and ankle is present in this patient. Airway assessment, both AP and lateral assessment has to be done. And here you can see that there is a large tongue, limited movement of the head and neck, which can impede the safe airway management. Now, various studies have shown that the incidence of mask ventilation, difficult intubation, and difficult laryngoscopy are high as compared to general population. One study pegged the incidence of difficult laryngoscopy and intubation as 24% and 11% as compared to 9% and 3% in the general population. And there are several factors that contribute to difficult airway in patients with acromegaly, and these include macroglossia, prognathism, enlarged glottis, hypertrophy of laryngopharyngeal soft tissues, and neck mobility. Now, generally, neck movement, Mallampatti grading, upper lip bite test, thyromental distance, tumor size, and hormone level are expected to provide some idea about difficult airway, but several studies have shown that they may not necessarily predict difficult airway despite performing each of these tests. Combination of one or two tests has a higher predictability than single test. Now, perioperative issues in acromegaly include cardiovascular and pulmonary morbidity, airway management, as I already explained, hemodynamic instability is likely, fluid management and need for invasive lines, especially the invasive lines may be difficult because of acromegaly changes, metabolic changes like refractory hyperglycemia, position and nerve injury are likely in patients with compressive compartment syndrome in patients with acromegaly. It's not just anesthesiologists which face problems, surgeons also face problems, and anesthesiologists can help in minimizing the problem faced by the surgeon during the transnasal transperineal endoscopic pituitary surgery. During the nasal phase, visualization and hemostasis are important. The edematous nasal mucosa and hypertrophy of the septum and turbinates can prevent good visualization and result in bleeding. During the sphenoid phase, bone removal becomes important to optimize the space, and there may be a lack of correlation between the imaging findings and the actual anatomy during the endoscopic visualization. During the cellular phase, when the tumor decompression is actually going on, the increased cellular floor thickness, tumor extension, the supracellular and paracellular region, and bone invasion, and anatomical variations in the caliber and course of internal carotid artery can predispose to difficulties for the surgeon. Now, ICA injuries, epistaxis, transient diabetes insipidus, hyponatremia, CSF leak are some of the common problems in post-operative, but can also occur during the intraoperative period as well. Now, this was one study published long back, which looked at intraoperative issues, and they found that hypertension, diabetes, and cardiomegaly are quite common, and this results in airway difficulty. And they found that the requirement of fiber optic intubation was higher in these patients, and that is because of the enlarged tongue. Amongst the metabolic changes, they found lower pH and higher blood glucose and positive blends as a complication for during anesthesia. So this was a patient where there was bleeding during the surgery, and later it was found that there was an ICA rent, and this need to be secured using coils and parent vessel trapping in the endovascular suite. And eventually patient underwent definitive surgery for the pituitary adenoma, and patient did well after surgery. So what are the goals of anesthesia in patients undergoing transnasal transperineal endoscopic pituitary surgery? One is the safe airway management. You need to use a flexometallic tube fixed on the left side, and because the surgeon mostly goes to the right, and a throat pack has to be inserted to prevent secretions and blood from trickling down into the oropharyngeal structures into the trachea. Hemodynamic stimuli is important because there can be intense stimulations which results in significant elevation in the heart rate and blood pressure, and then there could be periods of silence when there is no stimulation, resulting in hypotension and bradycardia. Anesthesiologists should make every effort to facilitate good surgical exposure, and this can be achieved by lowering the blood pressure, providing good nasal preparation, etc. Organ protection becomes important, and this includes renal function, hepatic function, cardiovascular system, and respiratory system as well, and brain protection, of course. Monitor for and manage complications. As I mentioned in the previous slide, there can be a sudden rent in the ICA. You need to lower the blood pressure, facilitate packing, and facilitate transfer to the cath lab, perform the procedure in the cath lab, bring back the patient to ICU. So these are some of the things which anesthesiologist can and will have to coordinate with the surgeon. Quick and smooth recovery is important in any neurosurgical procedure, but more so for endoscopic procedure, because generally there is a lag in the last step of the surgery and the first step of recovery, reversal. There is a very minimal gap as compared to the craniotomy and the open procedures. And therefore, short-acting drugs, which I mentioned earlier, should be used. Coming to the anesthetic management, induction is titrated dose of induction agents such as thiopentone, propofol, itomidate is fine. Airway management, fit mask, video laryngoscope, and fibroid may be available, should be available especially for Cushing's disease and acromegaly patients. Both balanced anesthesia and TIVA have been used. There is, as of now, no evidence to suggest one is better over the other. TIVA may be preferred because of less vasodilatation. Preparation of the nose is most important. You have to use local anesthetic plus vasoconstrictors, phenylephrine or adrenaline or xylometazoline drops, and then also prepare using anti-solution betadine so that the infection chances are less. Now, there may be, as I mentioned, periods of intense stimulation. Therefore, blood pressure and oxygen management becomes important. The anesthesiologist may be required to place a CSF drain or manipulate the carbon dioxide to bring the tumor into the cella from the paracellular region. Monitoring, standard monitors should suffice. Arterial monitoring is desirable to perform blood gas analysis, frequent electrolytes, glucose assessment. You should avoid fluid overloading and, if possible, glucose-containing solution, especially in Cushing syndrome and acromegaly, where glucose levels are likely to be high. Lastly, anesthesiologists may be asked to perform Valsalva maneuver to check for any CSF leak. So this is one study published by one of my colleagues where he demonstrated the benefit of using dexmedetomidine in transplant surgery. It provides excellent condition, minimal blood loss, good vision, visualization of the structures, faster recovery, reduced hemodynamic changes at crucial time points, such as the packing of the nose, speculum use, sphenoid dissection, cellular dissection, and after extubation. Coming to the post-operative care, cardiorespiratory adverse events are likely in the immediate post-operative period, hence vigilance is needed. Pulse oximeter monitoring supplemental oxygen can benefit patients who are likely to develop post-operative respiratory complications. CPAP and high-flow nasal cannula, though helpful, can be challenged after endoscopic transnasal transplant surgery. Frequent neurological assessment is important in these patients to watch for any metabolic and electrolyte parameters derangements and also neurological derangements. CSF rhinorrhea and diabetes should be closely watched for, as these are some of the common complications encountered after transnasal transplant endoscopic pituitary surgery. The last item I'm going to discuss is craniosynostosis. Is not often done in our center, but in young children, especially below 6 months, endoscopic strip craniotomy is performed. What is craniosynostosis? It is the premature fusion of the cranial sutures, resulting in abnormal skull development and head shape. These are the sutures that can have premature fusion, resulting in trigonocephaly, scacocephaly, brachycephaly, and plagiocephaly. So, what is the advantage? Less invasive, less blood loss, shorter hospital stay, small incisions. So, what are the considerations for endoscopic strip craniotomy? The surgery is generally performed very early in life, 4 to 6 months. Position becomes very important. They are generally Sphinx position is used. Raised ICP is a concern. Intellectual and neurological development is an issue. Airway management can become a challenge at intubation, extubation, and retaining of the tube in position. Associated syndrome are important and these should be considered, and complications and concerns associated with each of these should be noted. I have given 2 examples here, Apert and Prusal, which are more commonly associated with craniosynostosis. These Apert syndrome patients have mid-phase hypoplasia, colonic atresia, tracheal stenosis, high arch palate, C5C6 fusion, congenital heart disease, renal abnormalities, difficult IV access, and obstetric pneumonia. All these can be of concern to the anesthesiologist. Similarly, for Prusal, difficult mask ventilation, difficult intubation from high arch palate and retrognathia, proptosis requiring eye protection has to be considered. Apart from these, during endoscopic strip craniotomy, though the blood loss and hemodynamic instability are less as compared to the open procedure, these can occur along with hypothermia and air embolism, and this should be kept in mind during anesthesia services for endoscopic strip craniotomy. So these are the two steps, how the skin incision performed and the bone is removed through the incision using endoscope, and meticulous dissection to separate the bone from the sinus, which can result otherwise in excessive bleeding. I must thank here Dr. Dhaval Shukla, who has provided some of the images for this presentation. To summarize, patients for endoscopic cranial surgery present unique challenges. Thorough knowledge of pathophysiology, surgical approach, and perioperative issues are important to achieve good outcomes. Safe airway management, hemodynamic stability, and swift, smooth recovery are key elements for good anesthesia care in patients undergoing endoscopic cranial surgery. Lastly, vigilant cardiorespiratory, neurological, and metabolic monitoring is essential in the immediate post-operative period to achieve good outcomes. Thank you for your patient hearing.